aim of theranostic was personalized treatment. The power of theranostic was giving more choice to the patients to participate in the process of care.
I think probably only about 5% of patients who could be or should be getting this innovative new therapy are actually getting it.
The whole idea of precision medicine or personalized medicine is around profiling a patient as a person.
I think that pharma needs to understand the complexities of creating a facility, of hiring the experts, including nuclear medicine technologists and physicians.
Empower the patients to meaningfully participate in the process of care.
So good afternoon, Babak, Eliot. Nice to see you both. How are you today?
I'm doing really well. I hope you're doing well too. Here in the Bethesda area, it's sunny and warm, and sounds like spring is actually arriving. We'll see if that holds up, but doing really well. Thanks. It's really a pleasure to be here. Babak?
Absolutely. It's a pleasure having an interesting topic and a very hot topic, particularly because it's about the radioactive material.
Yes, it is. I was so excited that both of you were available and to be on the show and share your expertise with the audience. You have so much experience and insights to share. To get started. Maybe, Eliot, let me ask you to get started, maybe give a brief overview of United Theranostics, where both of you work, and then maybe start with your role, what you do there. And then Babak, I'll ask you to kind of chip in and give a little bit about your background as well and what you do.
So Babak and I are both founders, along with Dr. Michael Morris, of United Theranostics. And United Theranostics was really created mainly to allow patients who are eligible for this incredibly pioneering therapy of theranostics, which really means a combination of therapy and diagnostics together. And we'll talk about that a little bit more. But to be able to bring that type of cancer therapy to patients as nuclear oncologists, the three of us as founders really were excited about the potential to enlarge on the initial center that Dr. Morris and Dr. Saboury both had set up in the Baltimore area, and had talked a little bit about, well, what can we do to bring access to patients throughout the entire United States? And so what we decided would be to try to go after a really very ambitious project, which is to try to bring theranostics out in an outpatient environment, out to the neighborhoods of patients pretty much everywhere. I think probably only about 5% of patients who could be or should be getting this innovative new therapy are actually getting it at this point. And a large component of that is the fact that patients need physical access to the therapy. And so we created this national entity, and the entity is now in the Baltimore area. We're just opening up Bethesda and Los Angeles. We already have Las Cruces, New Mexico operational. Princeton is operational, and we're opening Chicago sometime in the next few months. And so we're expanding really rapidly, and it's been really exciting to know that our practice is allowing patients in all of those diverse geographic areas to be able to have access to both clinical theranostics treatments and also clinical trials, which are so important. In addition to the two radiopharmaceuticals that you'll hear about so often, Pluvicto for prostate cancer and Lutathera for neuroendocrine cancer, there are over 150 other radiopharmaceuticals that are currently being investigated for all sorts of different types of cancers. And so the ability for us to be able to conduct clinical trials in diverse geographic areas and to be able to provide clinical care and diagnostic care in nuclear medicine as nuclear oncology specialists, it's really been the purpose of setting up United Theranostics. And it's been really exciting to see it grow so rapidly within a relatively short period of time.
Thanks for that intro, and Babak, over to you.
So we had the opportunity to be at the crossroad when the new technology of theranostic came to the market, and we realized core problem that medical community and patients are dealing with is the difference between availability and accessibility. You may think, and many of the audiences may conflate the concept of availability and accessibility. Why there is a huge gap between these two concepts. A treatment might be available but not accessible. And there are many barriers for accessibility. In addition to the concept of access, one very important point for us is meaningfulness of access. Because in the name of access, people may bring something to the people in need and create a pseudo access. It's like when you have in the community hunger and you bring a junk food, and in the name of addressing the hunger, while it's only concealing the hunger by bringing those less nutrient food to the community. So availability to accessibility, accessibility to meaningful accessibility, and sustainability of that meaningful access. The last component is that all of these are in the ecosystem that should be sustainable. You don't want to have something that is great but cannot be there for a long period of time. So the idea of creating a platform for sustainable, meaningful access to radiopharmaceutical in both clinical and clinical trial setting was the premise and the mission of United Theranostics. And as Dr. Siegel mentioned, emergence of the nuclear oncology and oncoradiology is the core medical expertise that make this mission possible.
Great intro. Thank you for that background information. And I think maybe before we really start diving into some of the bigger sort of care coordination challenges and opportunities from in the market, I think a lot of our listeners probably don't really fully understand what theranostics are and radiopharmaceuticals and how they're utilized in clinical practice today. Could you maybe break down, because they're so different than the sort of the traditional product or therapy that a patient might receive. So can you define what theranostics is and RPTs and how you're utilizing them in practice today?
RPTs stand for radiopharmaceutical therapies, and theranostics really is a portmanteau combination of the term theranostics and diagnostics. And it turns out that we have the capability to be able to add to the many really fascinating advances that have taken place in cancer treatment. And in addition to the chemotherapies and the immunotherapy and checkpoint inhibitors and a variety of other approaches, it turns out that cancer cells are susceptible to a treatment with radiation. And we're all pretty much familiar with external beam radiation or brachytherapy, short-term radiation, for example, for prostate cancer and a number of other cancers. But it turns out that we can do something that's even more targeted to cancer wherever it may be throughout the body. And that is, if it turns out that we can find individual cancer cells and be able to send a treatment just to those cancer cells. It's sort of been the holy grail, I think, of oncology, is trying to figure out a way to be able to identify cancer cells and be able to treat and actually kill those cancer cells, and being able to do it in a precise way without harming surrounding soft tissue and minimizing other damage. And so radiation therapy has been used when there's tumor that we know exactly where it is and can localize where it is to a particular area. But it turns out we can also inject radioactive materials that can be targeted or programmed for particular types of cancer cells. We've talked about prostate cancer, for example, and there's a prostate-specific membrane antigen that is expressed or overexpressed in cancer cells. We can actually create a molecule that is designed specifically to find attached to those cells and then get engulfed in and incorporated inside those cells. And so because of that, we can actually image cancer in patients with prostate cancer throughout the body by injecting PSMA that is radioactive and create an image on a PET scanner. But what we can also do, and this has been a relatively recent development, is in addition to being able to image those cancer cells wherever they may be within the prostate, outside the prostate, in lymph nodes or anywhere else, we can also essentially then target a therapy that also utilizes that PSMA as a mechanism to be able to find and attach to the cells, only we can deliver a radiation particle. In the case of Pluvicto and Lutathera, it's a beta particle, but we can also treat with alpha particles or other types of particles that allow us to be able to kill the cells. So in some ways, it's kind of like Fantastic Voyage, if you remember from many years ago, where a submarine was miniaturized, injected into a patient, and then it ended up finding the patient's pathology and then treating it locally. Well, we're able to inject these programmed nanoparticles that are radioactive, that are able to find individual types of cancer cells that we program them for, get engulfed inside of them, and then kill the nucleus of those cells. And it's been a really elegant way to treat patients, and it also minimizes the side effects. And so the ability for us to be able to see the cancer with our PET CT scanners or SPECT scanners and treat the cancer, then see it again, allows us to participate in this paradigm where we see it, and treat it. And so unlike with chemotherapies in general, we have the capability of being able to actually see exactly where our treatment went, measure how much of the radiation was delivered to the tumor cells, how much was delivered to surrounding tissues, and then be able to tailor and target it. So it is the absolute best example that's out there right now of precision medicine or personalized medicine for patients. And we're able to use a combination of our diagnostic skills as radiologists and our skills in oncology to become nuclear oncologists, to be able to treat patients with an ever-increasing number of different types of cancer.
I think that's a very powerful way of describing it, to see it, to treat it, and then see it again, to see the impact that you've made on reducing that tumor in the body. Babak, over to you. I think, could you maybe go a little deeper around how you are actually using these radiopharmaceuticals and diagnostic today to treat, what types of patients are you able to treat with these therapies today?
The whole concept of theranostic is extremely novel in a sense that, as Dr. Siegel mentioned, the whole idea of precision medicine or personalized medicine is around profiling a patient as a person. And instead of treating the average person, treating the person that is in front of you. In order to do that, imaging play a fundamental role. Nuclear oncology without a person who has expertise in imaging is not going to work. You need to have the vision to see the individuality if you want to tailor the treatment to the need of the person. So that is the reason that nuclear oncologists are the people with deep knowledge in radiology, and they are oncoradiologists at the same time, because you need to see and you need to have the capacity to interpret a variety of appearances and then see how I can tailor the treatment for the need of this particular patient instead of treating average patient, which is nobody and everybody at the same time. So in neuroendocrine tumors and in prostate cancer, two major type of the cancers that theranostic play a very important role, as Dr. Siegel mentioned, they have a fingerprint. All of these cancer cells have a fingerprint that are small molecules go and find those fingerprints. These small molecules, one time is labeled with imaging radionuclide, so we can see where they are, profile the lay of the land. And the other time you can just like label them with the destructive radionuclide that create a locoregional impact. But very important point, in the beta particle emission, the range of these beta particles are about maybe 20 cells to 100 cells. In alpha particle, when they are going, they impact about 4 cell, 5 cell. Extremely precise. It's as if that you have a scalpel and you microsurgically remove all of these metastatic niches.
A microscalpel.
Microscalpel.
Yes.
Yes. And that is the very, very important and potent capacity that bring here. So again, one may say theranostic or nuclear oncology is what Dr. Siegel mentioned about treating what you see and seeing what you treat. And on the other hand, you may say what it is not. So historically, when you have a cancer, either you had a locoregional treatment of the cancer by surgery or by external beam radiation, or you had the capacity to systemically treat the patient. This is the first time that you combine the two together. It is neither pharmacotherapy nor radiation therapy. It is both pharmaceutical therapy and there is a radiobiology also there. And because of that, we call that radiopharmaceutical therapy.
And Babak mentioned a really important point about precision medicine. So when I'm in the clinic and I'm seeing a patient, I am looking at that patient's laboratory information, renal function, blood work of all sorts of different types. And I'm also looking at the patient's genomic information. I'm looking at the dosimetry data that we have from prior treatments, how much of the treatment went to cancer cells, how much of it went to surrounding soft tissues, prior treatments that the patient has had previously, and combining that genomic data with all the imaging data, not just with PSMA prostate scans, but other types of PET scans, such as FDG, other types of imaging, combining all of this incredibly complex information that is specific to one patient in front of me, and then taking all of that information and making treatment decisions about the patients. And so it's really been fascinating to be able to combine our expertise in diagnostic imaging with all of the information that is available today for treatment of oncology patients and expertise in that area. And so patients are sent to us as neuro-oncologists, and we're able to get the best, most precise treatment, whether it is just radiopharmaceutical therapy or whether it's in combination with other types of therapy that our colleagues in radiation oncology or our colleagues in medical oncology would be using to treat the patient.
And that is an extremely important point, that nuclear oncology and precision oncology that we are talking about empower the patients to meaningfully participate in the process of care. Because if you don't have the understanding about individuality of the person, your communication with them is suboptimal. You may say that, oh, there might be some side effect or may not be. You may just like benefit or you may not. And again, although that looks like that you are participating them in the process of care, in reality, you are not empowering them to meaningfully participate. However, in nuclear oncology, particularly by dosimetry, you just like sit with the patient. You show them that where are these molecules? What, based on that, how you can expect and they can expect to have a specific side effects, and give primacy to the goal of care for the patient. Because people have different outcome of desire. Not everybody think the same way.
It's really gratifying to sit down with our patients in front of the view box and go over the images and demonstrate the improvement over time, demonstrate their dosimetry to show them that the treatment actually did go to these particular tumors, and to work with them to determine what is the pace of treatment for these patients. Should it be the formulaic pace that was part of the original trials that were done on patients, or should it be tailored to the patient's laboratory information and the dose information? And so a major component of personalizing the care to the patient is carefully, after every treatment, measuring the dose over multiple periods of time after the treatment, where we watch as the radiopharmaceutical therapy actually washes out of the body, and that washout rate is different in every patient. And so for every patient, the dose to healthy tissue and dose to the tumor varies, which then informs the next treatment.
So very good introduction to the modality. You've got me very interested and excited about the power of this treatment modality. But I wonder now if you could tell me a little bit about how much time and coordination it actually takes to deliver this with the current system we have, taking a patient from diagnosis all the way through their first treatment with a radiopharmaceutical therapy. What's involved in that? Because it sounds complex, right?
Yes, it is.
It is. It's even more complex than it sounds as you describe it.
So science is complex, production is complex, but nothing is more complex than humanity and human. Because at the end of the day, you are dealing with a human with all the feelings and ambitions and desires, and you are dealing with a person that is suffering from a very life-threatening situation. So all of these little nuances will be much more meaningful when you consider all the elements around and surrounding the condition. It's not this the cancer is not the disease of the person who is suffering from that necessarily. All the families involved. I mean, the loved ones are in pain in the same way that the person who has the disease, and many events are passing by. The granddaughter that is getting graduated, or the daughter that is getting married. So having all of these societal and psychological aspect, bringing that to the complexity of the planning, and then on top of that, considering the just-in-time production of these radiopharmaceuticals, add to the complexity in exponential manner. But at the end of the day, it is the person who is at the center, and everything should serve that end and that goal. So one very important point that many of the pharmaceutical companies don't get it when it comes to the radiopharmaceutical therapy is the fact that patients demand more active involvement in the process of care. And that might not be necessarily the thing that majority of the pharma used to, because they may just like prefer a more production line and just like expansion rather than just like empowerment. And that's natural. Again, there's nothing wrong with that. The agencies are different. Never in the world a pharma can claim that we are putting the best interest of the patient in front of us. They didn't have the oath to the patient, and they have the best interest of their shareholders. They should have. But at the same time, physicians in this ecosystem play their own role. They are there to stand by the patient and say, I promise that I only have one objective here, and that is maximizing your benefit. I put everything else behind and beside, and I promise that even if I cannot cure your disease, I care about you, and any action that I do has that element of care.
Given the complexity that we're talking about, you would think, and I think many patients think, I think many folks from pharma, many of the physicians taking care of patients think that the place that can handle that level of complexity or should handle it is at the hospital level. But what we actually find is that looking at the logistics associated with getting the right radiopharmaceutical at exactly the right time, because the radiopharmaceuticals, as you know, decay progressively over time, being able to have the patients logistically get to the right place at the right time, which can be really complex in a hospital environment, being able to do all of the things related to ordering the radiopharmaceutical, coordinating with the hot lab, coordinating with the right personnel, technologists, physicists. It turns out that actually hospitals, in my experience, even in the best academic centers, really struggle because of so many things going on, so much noise in the hospital, so many difficulties for patients to even find the theranostic center within a hospital to be able to park. And so part of our idea was to make this as simple as possible for the patients, only doing nuclear oncology, only essentially having a center that just does theranostics and diagnostic nuclear medicine and clinical trials, really turns out making it much more straightforward for referring docs. The whole process of, in general, currently having a physician have a patient who may get referred to an outside an outpatient facility for diagnostic imaging study, and then get sent into a hospital for the theranostics, and being able to coordinate with multiple complex handoffs can be really daunting. And having sort of a one-stop shop that is an outpatient shop that specializes specifically in therapeutics and diagnostics, and having those localized close to the patients, really turns out to be a much better delivery model for the patients, and paradoxically is able to provide better and more consistent care than even some of the most sophisticated academic hospital centers.
I'd like to ask both of you real quick. We'll close out this section and move on, but I'd love to ask each of you to respond around what is the one thing that patients are most surprised to learn when you're in that initial consult with them? What is the one thing they're most surprised to learn about this treatment modality, if it's appropriate for them? There's something
my own experience, and I'd be interested in Dr. Saboury, is the fact that it's so relatively easy and painless with so relatively few side effects. I think patients come to us and they've had a number of different chemotherapies. They've had androgen deprivation therapy, essentially chemical castration. And I think the patients are really wary when they're told, oh, here's one other treatment. And as we talk about some of the, side effects of this, they're really minimal. I mean, dry mouth or xerostomia. Some patients have some change in sense of taste for some period of time, but really in comparison to those others, they're relatively minimal. And I think the patients are really surprised, even when they're, told that, how relatively easy and painless, and the minimum number of things that they need to look out for in comparison to what their experience has been already.
Yeah, so I always realize that when you're explaining these principles to the patients, they expect you tell them that we have a plan to implement that in the next 20 years. And maybe if we are lucky and everything goes with as we plan, maybe in 20 years or 10 years, we have such a platform. But when they realize that we already have these things in our armamentarium, they get very surprised. And one thing that is always important to me is that we see many patients that are coming to us and they received radiopharmaceutical therapy in the locations that were not really specialized for that matter. They gave it as a shot and without the due diligence, and they suffered. They suffered because their kidney function had some impairment. They suffered because nobody even communicated to them that how these therapies may negatively impact them, and nobody considered those things in the planning of the care for them. So again, one thing that is again very important for us, patients always remind us how much they are appreciative of this theranostic paradigm, because that empowered them to participate in the process of care. And that is very important. Radiopharmaceuticals are one of those treatments that are very safe and very dangerous at the same time. They are very safe if that's in the hand of the person who know how to deal with them, and extremely dangerous if people want to just like give it for the sake of just like providing something. So you need to have expertise, you need to have the due care, and you need to have technical capacity to maximize the benefit of this and minimize the potential side effects.
Do you remember the TV series Cheers? And one of the slogans was, where everybody knows your name, and it was really welcoming. And coming into an environment where you may be treated over a period of 36 weeks, baseline for Pluvicto for 6 treatments every 6 weeks. And then you may have additional treatments beyond that, which, we see really commonly patients continue to follow with us. And as soon as patients walk in, to a sort of their neighborhood theranostic center, everybody knows them, knows their name, knows about their families and history and some of the unique challenges that they have. And I think patients are really surprised in many cases by, going into an environment that's really welcoming and really supportive for their needs as well.
And that is the magic of technology, because in the past, it was only in the ivory tower that you could have the best of the best of the best. And people had that sense of alienation when they were in those environments. Yes, it was with the promise of having the best, but it had the side effect of not being around your familiar faces. However, in 21st century, in 2026, by advances in AI and all the other technological advances that we have, fortunately, we can bring the most advanced care for the patients in the location that they are living, and that is in itself a very happy achievement for all of us.
Indeed.
Eliot, you mentioned at the outset that only about 5% of the patients who may be eligible for these treatments
Yes.
are currently able to get to an institution like yours to be worked up and for their eligibility to be determined. Let's start to dive a little bit into what's behind some of that. Where is the breakdown? Why is it so difficult for patients to get into centers, theranostic centers? I guess for the audience, it's important to know too that these aren't therapies that you can just kind of walk into a provider down the street, your primary care, and have them order it for you. There's so many specialists involved in your practice to deliver this care. So maybe tell us a little bit about that, and where are the breakdowns, like in the handoffs from one specialist to the other, that sort of prevent more patients from getting to physicians like you to be treated?
Yeah, well, first of all, I really appreciate you inviting us to this discussion, because I'm constantly surprised at how many urologists or how many medical oncologists really are heard about it. They've gone to meetings, but I think they're really not aware of some of the most recent breakthroughs and some of the most recent results and trials in patients. So I think a lot of it is really educating the practitioners themselves and also letting patients know that this is something that they can ask their providers for. So a lot of it is really continuing education of our colleagues. Another part of it is the fact that, as you mentioned, it's really difficult to find centers. One would need a radioactive materials license, a RAM license, which the vast majority of oncology centers do not have. One also needs to be able to have the diagnostic equipment, PET CT scanner, SPECT scanner, to be able to do the imaging portion, the see it portion of it. And so, and then the infusion portion of it really requires fairly specialized facility that has the ability to be able to have the proper lead shielding, the proper hot labs. And
if you enjoyed this conversation, be sure to subscribe to the RX for Biotech podcast to hear directly from the leaders who are shaping the future of personalized medicines. And if you or someone you know is navigating a care journey, be sure to visit therapyforme.ai to search for a specialist near you. And if you need that extra support, be sure to schedule a virtual telehealth appointment with one of our nurse navigators who can help answer your questions. Thank you for listening.